Welcome everyone to the Citywide Psychiatry Grand Rounds. It's a pleasure to be here today with our Sunnybrook team. I will start by the land acknowledgement. I would like to begin with an acknowledgement of the land on which we work, study, and live. Before I read it, I want you to take a moment to situate yourself and think about the land under and around you. We recognize that many Indigenous nations have long-standing relationships with the territories upon which the sites of the Department of Psychiatry are located that precede the establishment of the University of Toronto. We acknowledge our presence on the traditional treaty of many Indigenous nations, including the Mississaugas of the Credit, the Anishinaabe, the Chippewa, the Haudenosaunee, and the Wendat people. Today, this land is home to diverse First Nations, Inuit, and Métis people, and we're grateful to have the opportunity to live, work, and gather on these territories. We acknowledge that Toronto is covered by Treaty 13, signed with the Mississaugas of the Credit, and the Williams Treaty, signed with multiple Mississauga and Chippewa bands. Since this event is a virtual gathering, a singular land acknowledgement does not capture the richness of our distribution across many locations. There are few places on earth that someone before us has not called home. Thank you. Now I'll just quickly go over some housekeeping items. Today, as I said, we're really grateful for Dr. Rector and Dr. Richter and the Sunnybrook Health team for presenting. There'll be an evaluation link that'll be sent to attendees after the presentation. Please, your feedback is always appreciated. And this is the next Citywide Psychiatry Grand Rounds. Without further ado, I'm going to pass it on to the Physician-in-Chief of Sunnybrook Health Sciences, Dr. Ari Zadetsky, to welcome the two presenters.
Thank you, Dr. Rajasingham. It's really a pleasure for me to introduce these two outstanding colleagues of mine at Sunnybrook. This is a very brief introduction because to actually allow them to have more time to present, I've had to kind of shorten the introduction and all their accomplishments. So Dr. Peggy Richter is the inaugural head and co-lead of the Frederick W. Thompson Anxiety Disorder Center at Sunnybrook and heads the sole residential treatment program for severe OCD in Canada. She is a professor of psychiatry at the University of Toronto, and she is internationally known for her work in OCD, focusing on exploration of the genetic and biological basis of this illness, novel treatments, and improving outcome. Her funding sources include the Canadian Institute of Health Research, Ontario Mental Health Foundation, National Institute of Mental Health, and the International Obsessive Compulsive Disorder Foundation. Dr. Richter is the author of over 100 peer-reviewed publications and also sits on the boards of several advocacy groups, including the Scientific Advisory Board and the Perinatal Task Force of the International OCD Foundation and the Canadian BFRB Support Network. Dr. Richter co-chaired the development of Ontario Quality Standards for Management of OCD and Anxiety Disorders. She is an internationally acclaimed speaker on anxiety, presenting extensively to both healthcare professionals and lay audiences. And with her this morning is Dr. Neil Rector, who is a senior scientist, a senior research scientist at the Sunnybrook Research Institute and director of research and clinical training in the Frederick W. Thompson Anxiety Disorder Center, as well as director of the Mood and Anxiety Treatment and Research Program at Sunnybrook Health Sciences Center. He's also a full professor in the departments of psychiatry and psychological clinical sciences at the University of Toronto. Dr. Rector's research interests focus on the study of cognitive and behavioral mechanisms of vulnerability in the development and persistence of anxiety and OCD and their treatments with CBT. His research has received funding from this Canadian Institute of Health Research, Social Sciences and Humanities Research Council of Canada, and the Ontario Mental Health Foundation. And his research has resulted in more than 100 publications and book chapters and 7 books published or in progress. So without further ado, I'm very excited to pass the virtual mic to my colleagues, Dr. Richter and Dr. Rector. Over to you.
Great. Thank you so much, Ari and Dr. Singham and everybody at U of T for having us today. Let me get my slides up and make sure that we are good. Can everybody see that?
Yes, that looks good.
Great, thank you. Okay, well, it's a pleasure to be here, and it's a pleasure to be doing this with my dear friend and colleague, Neil Rector. In case anybody is wondering, we are not related. Our names sound alike, and it's been quite enjoyable for us having that funny near relatedness in our names for many, many years working in the OCD area. And I'm going to take us, I'm going to open today with a bit of an introduction to OCD and what we do at the Frederick W. Thompson Center. We'll then be hearing from Neil, who will be telling you all about his really elegant systematic approach to research into the biology and psychology of OCD. And then I'll be coming back at the end just to highlight some other research that is going on in our center as well. So that's our goal for today. My disclosures, which I don't think will pose a problem, we will clearly identify anything that is indicated rather than or research-based. So my objectives for today are to outline current knowledge of biological and psychological factors contributing to the vulnerability maintenance and treatment response in OCD. And we will be going into current or recent completed research in OCD within our center. Okay, so with that, let's go through a very brief reprise of OCD, although I know in this audience, everybody here is very familiar with it. We're talking about a disorder characterized by the presence of intrusive, unwanted thoughts, images, or impulses, which typically are viewed as anxiety-provoking and often can be described as sticky or ego-dystonic, to use an older term, and are typically accompanied by compulsions, which are repetitive behaviors or mental acts, again, typically done in response to an obsession, although it is important to recognize there are some individuals with OCD who will not be able to identify their obsessions, or others who may have difficulty identifying their rituals or compulsions. And the function of the compulsions typically is to reduce the anxiety. For diagnosis, we typically look at one of these three severity markers that symptoms cause marked stress, waste at least an hour a day, or interfere with functioning. I'm going to skip that. Now, having said that, I think everybody is intimately familiar with the common presentations of OCD. It is important to keep in mind, though, that OCD can really revolve around virtually any kind of thought that you can conceive of. And that is part sometimes of the diagnostic confusion that can result. So at the top of the list here, I have common things like checkers, people who are concerned about inadvertently being responsible for a bad event or a catastrophic outcome, a fire if they didn't turn off the stove, a break-in if they didn't lock the door, and have checking rituals. Washers typically are individuals with contamination concerns, worries about dirt and germs, who are engaging in a lot of cleaning and washing rituals. But again, this being OCD, nothing is ever totally straightforward, and you will certainly see individuals with compulsive washing who will say they have no worry about the consequences whatsoever. So again, OCD can vary a great deal. I like to highlight the bad thoughts domain because or the taboo thoughts, because many people are reluctant to inquire about them. And if they are not asked about, it's a real missed opportunity, because this is often the most disturbing and distressing domain individually for individuals with OCD. So here we are talking about violent thoughts, for example, thoughts of stabbing a loved one, running people down with their car, smothering their infant, intrusive, disturbing sexual thoughts that are not pleasant to contemplate, even as fantasies. So thoughts that go against their orientation and that are not things they want to be thinking of, sexual thoughts about parents, children, other inappropriate people in their lives, and other types of taboo thoughts. For example, those that go against religious beliefs or are sacrilegious or immoral, or are about using racial slurs, for example. Anything taboo that you can think of would go into this grouping here. And I also wanted to highlight, for many people, OCD is about just right. So they may have difficulty in these situations identifying those obsessions and focus rather on the need for things to feel right in the moment. And that is triggering repeating of actions, perhaps checking rituals over and over, or repeated washing, not because of a concern about an actual feared consequence, but just because it doesn't feel correct in the moment or complete. There's also mental contamination I wanted to highlight, because this is one that's often misunderstood. And these are people who will link any object or place they were in at the time of a bad thought with a feeling of contamination or a fear that that bad feared consequence will happen. So because they had a thought of their mother dying when they visited me at my old office in CAMH, they were no longer able to see me in CAMH and might even discard the clothing they were wearing that day for fear that wearing it might in fact lead to that feared event. But again, OCD can be really anything. So why are we here talking about OCD? In part because of these 4 characteristics. OCD is common. It affects about 2.5% of the population over a lifetime and a far greater percentage of psychiatric outpatients. It tends to be severe for a large number. About 30% would be characterized as severe by most studies that have looked at this, and has been at times listed by the World Health Organization as up to as high as the 10th leading cause of disability worldwide. It's very highly comorbid. So about 70% will have depression, 50% will have another anxiety disorder, and at least 15% or 20% will have other OCD-related conditions, such as hoarding disorder, hair pulling disorder, body dysmorphic disorder, etc. And this is the real kicker. OCD tends to be chronic. The vast majority of adults do not attain long-standing stable remission. And even with pediatric onset, where we tend to think of it as typically improving with age, a significant proportion will still be ill years later. So with this in mind, OCD exerts a heavy toll, and I thought I'd just highlight some of these statistics for people. So I think this is a fascinating observation. A study by Wall et al. A number of years ago highlighted that 70% of people with a validated diagnosis of OCD were not diagnosed with OCD by their psychiatrists. They were in regular psychiatric care, had not received OCD as a diagnosis. Another rather startling fact is that people with OCD tend to be delayed 17 years after symptom onset before they actually get treatment. They're very impaired, 65% reporting severe role impairment. And then when it comes to treatment, most are not getting evidence-based care. So based on the Ruscio study in 2010, even of those with severe OCD, only a third were receiving OCD-specific treatment in the previous year. And when treatment is offered, it's often non-evidence-based. In fact, some estimates are that less than 30% receive exposure response prevention, our gold standard psychological treatment, and most are not offered SSRIs at OCD effective doses. So with this landscape, Frederick W. Thompson entered our lives in 2012. And I have to say, it's been quite the ride for Neil and I. At the time, his gift to establish the Thompson Center was the largest donation in Canada for anxiety disorders, and I believe still remains among the largest gifts in mental health, although there certainly are a few that are larger in scope now. And we launched the Thompson Center in 2013 as the only center that serves OCD and the related disorders specifically. Our name can be seen as a bit of a misnomer. It is a name we hope to grow into in coming years and treat all the anxiety disorder spectrum, but at present that's beyond our means and our scope. And our vision is that individuals with OCD and related disorders have access to state-of-the-art care. And we do that through our clinical care, research, and education. So I thought I'd highlight some of our major landmarks along our path. We opened our doors officially in 2013. We actually pivoted to focus almost exclusively in terms of the direct services we provide on those with more severe OCD after going through a careful strategic planning exercise in 2016. And I have to say that was a very wise move because that was the largest gap in our healthcare locally and across the province. And we were fortunate enough to get pilot funding to launch Canada's only residential and day treatment program to round out our outpatient services starting in 2017. We have been the only site in Canada to treat people with OCD with focused ultrasound. That's in collaboration with the Harquail Centre, and we're very proud of that work, and it looks incredibly promising, actually. And most recently, a recent landmark was that we were awarded permanent ministry funding for an expanded intensive treatment program, which I will tell you a bit more about today. Now, this is the landscape of what our program looks like. I just thought this might be of interest to those who are not so familiar with what we do. So we have our research arm, which you're going to be hearing predominantly about today. Neil, as our lead in research, is going to be telling you about a number of our most important projects, and I'll be ending with a few other smaller ones. Our education, we have a number of really lovely initiatives. We run an ECHO, which is a remote multi-site Zoom-based learning initiative funded by the Ministry of Health in partnership with CAMH, where we teach people the basics of OCD across the province and, in fact, CBT for OCD. We also have a partnership program, the Thompson Partnership Program, with 4 sites at this point across the province where we have trained the site on staff to deliver evidence-based care for OCD. And then we have our clinical services, the intensive treatment program, which I've touched on and will come back to, and our outpatient services, which are highly active as well, and provide an ideal venue for training, which is a big part of what we do as a major training site, taking psychology practicum students, as well as residents, OT students, social work students, and nursing students. And so last, I thought I'd share a little snapshot of some of our stats for those who are interested. So at present, we see roughly 375 individual patients annually, approximately. Our intensive program is quite small in scale, but we have been really quite proud to have welcomed 232 into our program since opening in 2017. Prior to that, at least 10 to 12 Ontarians per year would go to the US, and we knew it was a vastly underserved population. That barrier really scared away a lot of individuals who would really benefit from this treatment. We have a very active outpatient group program under Lance Hawley, and we run approximately 14 CBT and MBCT groups for OCD and the related disorders annually, although lately that number has probably jumped to about 20 per year based on one of the studies that Neil may be mentioning today. And in terms of some research landmarks, since 2013, we've held approximately 20 grants peer-reviewed, totaling approximately $23 million, and have about 88 published papers. So we're proud of ourselves. There's lots of room for growth in the years to come. And we see this as an exciting time for our program. And with that, I will turn it over to Neil.
Looks good.
You need to
mic's
unmute
just
yourself.
unmute. Yeah.
Hi, good afternoon. Thank you, Peggy, and thank you for the introductions, Ari. And it's very nice to have an opportunity to speak about some of the research that we're conducting at the Thompson Center. I thought maybe within the short time we've got today, I would give a short snippet overview of 3 recently completed randomized controlled trials where we've been trying to extend the evidence-based care of folks with OCD. I'm going to talk about our enhanced CBT randomized controlled trial, some of our developments in mindfulness for OCD, and then some of our recent exercise research in OCD. If we look at the current treatment guidelines based on evidence-based care for OCD, you can see it's pretty slim pickings. We've got two treatments, exposure and response prevention and antidepressants delivered at varying levels of severity across the condition. And then there's this idea at the end to maybe include adding cognitive therapy to enhance long-term symptom reduction or to help people who are having trouble engaging in ERP benefit from treatment. You know, it is interesting that until about the 1960s, OCD was seen to be largely an untreatable condition. And even though there's been lots of experimental research testing psychotherapeutic interventions, we really are left with exposure response prevention and perhaps augmenting with cognitive therapy as our lone psychological treatments, sort of meeting that benchmark of evidence-based care. So what is the treatment of OCD with, I'm just going to get my laser pointer ready here, with ERP? Well, the theoretical foundation for this treatment really emerged in the psychological laboratory. Here was Jack Rackman and colleagues showing that when you ask patients with OCD to put, for instance, their hands in a bucket of dirt, their anxiety rises, as does the urge to engage in washing their hands. And when patients are permitted to wash their hands, they feel a decrease in anxiety. And some of this early experimental work really answered an age-old question: why do these seemingly ridiculous rituals continue? And the answer from the laboratory was because they serve to turn off anxiety. And in the same research, Rackman and colleagues discovered that when you prevent a person from being able to wash their hands, for instance, that over time, both the anxiety and the urge to wash come down. And upon repetitive exposure, the anxiety starts at a lower level and the urge attenuates more quickly until eventually, after multiple exposures, the person may no longer experience any anxiety upon exposure to that original obsessional stimulus. And that probably can be demonstrated with all major clusters of obsessions and compulsions. And we've also come to learn a lot about how this works in safety behaviors. Here's a more recent experimental study exposing somebody to personally relevant health information. Their anxiety goes up, and if they're permitted to check the internet and maybe seek reassurance, they feel better. But if you give somebody the same negative health information, and you prevent them from being able to check the internet or seek reassurance, the anxiety and the urge to act on that also comes down. This very basic theoretical premise is the framework for exposure and response prevention. And here's kind of the narrowed down version of the intervention. We simply delineate the range of obsessional triggers for someone with the condition. We try to understand the range of discomfort that they may experience with each trigger. We establish a hierarchy with those triggers and their distress ratings hierarchicalized from least to more distressing. And then we try and systematically expose individuals to their triggers without letting them perform their rituals. And there's varying formats in the way this can be delivered. It can be delivered daily in intensive treatment programs like it started in the US. We can also deliver this twice weekly, or more commonly now, weekly in an outpatient session. Here's just an example of perhaps somebody with contamination-based OCD completing a hierarchy. And we would just work on exposing that person through each of those triggers repeatedly until those triggers no longer elicited the same discomfort. As Peggy alluded to in the intro, this really is our gold standard treatment for the condition. If you take people receiving intensive ERP, or in this case, ERP plus clomipramine, or clomipramine alone versus a placebo condition, and you look at post-treatment 12 weeks later, you can see that both the intensive ERP and ERP plus clomipramine end with very low Y-box scores. This is OC symptom severity, and we usually think about 10 being somewhere a cutoff for essentially illness remission. So I guess the point is that we can deliver a very effective ERP intervention with and without antidepressants, and that present tends to exceed the effects of medications. But 25% of people refuse to do this treatment because it is incredibly demanding. and it can be very uncomfortable to do until there's progress. We see about another 25% only experiencing partial response. And so when we factor in all of those broader numbers, we might say that we expect somewhere in the order of about 50% of people receiving these treatments to experience full response. And importantly, within the ERP treatment, the actual cognitive appraisals and beliefs that we think are very important to its development and its maintenance are not systematically targeted. Here is a different conceptualization of OCD emerging from the cognitive tradition. This is a Beckian cognitive therapy tradition, where the view is the problem isn't the arriving intrusion, but it's rather the appraisal and the meaning the person gives to the intrusion. And the view of this intervention is that the problem is in the appraisals in maintaining the anxiety, and the appraisals also shape whether or not the person engages in the rituals. And so cognitive therapy is interested in the meaning the person is making of their intrusions. And usually in OCD, the meanings that are being made of the intrusions are not endless. They tend to cohere around these themes. This was an international group of cognition researchers working about 2 decades or so ago, culling the literatures across 100 years of what we had come to know about OCD, and arriving at these really being the core dimensions that we think relate to both vulnerability for developing OCD and the kinds of appraisals that actually keep OCD maintained once it's started. We know in research over 2 decades, and it's a very voluminous literature, that when you measure these beliefs, they tend to be overrepresented in people with OCD compared to other conditions. And the severity of these beliefs also correlate with both symptom severity when presenting to clinics like ours, and also the extent to which they change when treatment's improving. And we use fairly standard cognitive therapy skills. For instance, most of you would be familiar with the thought record in helping people with mood and anxiety disorders. In OCD, we're using a very similar thought record, but the dimension of real interest is, what is the appraisal? What cognitive vulnerability is it emerging from? And can we get that person standing back and considering alternative evidence that doesn't support the appraisals emerging from these dimensions? We've got 2 very good psychological treatments. Here are the effects for ERP, here called behavioral therapy or cognitive therapy. This is a recent meta-analytic review of 86 randomized control trials, 7,600 patients. And we really see that somewhere in the order of about 80% or more of individuals with OCD receiving either ERP or cognitive therapy will experience either partial towards full remission. And these effects on average tend to exceed those observed in the medication treatment of OCD. It's curious, if we look at other international treatment guidelines for most other conditions, we see the integration of behavioral therapy with cognitive therapy, hence CBT. Historically, it was believed that if we tried to talk a lot to patients when they were doing their exposure tasks, that could end up interfering in their progress. And so the original ERP models really downplayed the role of cognitive appraisal work. At the same time, cognitive therapists said that engaging in exposures is a distraction from doing the deeper cognitive work. What we really want to do is test out beliefs and appraisals. So even though it seems intuitive that we would combine them, they're coming from different theoretical traditions and hadn't been done, even though our original NICE guidelines highlighted that we really should be integrating them. So we embarked on a CHR-funded randomized control trial testing exactly that. Based on our clinical work, we developed a manual that combined exposure and response prevention with cognitive therapy over our years of clinical work. And we wanted to compare that against a gold standard ERP treatment on its own, with the question, does the learning of the more complicated cognitive therapy to be embedded with ERP really lead to additional advantages, or does it actually somehow interfere in the success of ERP? So we do a large-scale randomized controlled trial. Many different types of patients with different types of OCD symptoms are represented. You can see our diagram, consort diagram here. And in short, our integrated CBT intervention outperformed the exposure response prevention at both post-treatment and 6-month follow-up. Both treatments were very successful, but it's true that the integrated CBT produced better symptom reduction, and that was maintained through the 6-month follow-up. Essentially, that difference is equivalent to about a medium effect size difference, the kind of effect you typically see in the medication treatment of OCD. And then here's just a follow-up. If we look at, a signal detection study shows 30% cutoff on the Y-box improvement is something akin to a successful treatment response. 50% equals something that we would approximate to what would be called condition remission. And you can see the improved rates for the integrated CBT versus ERP alone. One question is, why exactly is the integrated treatment outperforming ERP? One hypothesis is because it's actually targeting those underlying cognitive dimensions I highlighted earlier. And in the study, we did find that CBT produced greater improvement on those cognitive dimensions. With my postdoctoral fellow, Danielle Katz, and colleagues Judith Laposa at ChemH, and other members of us at the Thompson Clinic, we embarked on a more stringent test of whether or not it really is the reduction of obsessive beliefs leading to mediation of improvement in CBT for OCD by having 3 different conditions. These are approximately 330 patients, all receiving CBT for the respective condition, and each condition completed these cognitive vulnerabilities, one related to what we think is related to OCD, dysfunctional attitudes being specific to depression, and anxiety sensitivity being more specific to anxiety disorders. And when we looked at the mediation models of each of these conditions, it was what we had previously found and hypothesized, that in OCD, the only cognitive vulnerability that mediated positive outcome were reductions in obsessive beliefs. And the depression and anxiety related beliefs were unrelated to the improvement in OCD. Interestingly, it was the same for the others. OBQ and anxiety sensitivity didn't mediate outcomes to depression, only the cognitive vulnerability did. So we feel like we've got some pretty good emerging evidence that at least within the integrated CBT treatment of OCD, it's really occurring through improvements through reduction of these cognitive vulnerabilities. Okay, this is a fairly complicated slide. I'll do my very best from my great colleague statistician Lance Howley and colleague Zindel Siegel. We took another independent sample of 100 patients with moderate to severe OCD with our integrated CBT protocol that I've been discussing. And we looked at the degree to which Y-box or symptoms were improving across treatment. And we looked in fancy path analytic models, the extent to which either exposure tasks, both the quality and the frequency related over time to improvement, or the degree to which people completed thought records at a high quality and a high quantity. And in our path analytic findings, both exposures and cognitive therapy dysfunctional attitude scales completed, dysfunctional thought records, both independently predicted outcomes. And interestingly, both the behavioral and the cognitive bits equally predicted outcome. So we feel like we're really at a point now where for optimal treatment of OCD from a CBT perspective, we want these treatments integrated. So both ERP and integrated ERP plus CT are effective, but it does look like the integrated treatment is better. It actually leads to improvements at a significantly greater level across all symptom presentations of OCD. And it looks like the mechanism of action is largely to be through cognitive belief reduction of the negative beliefs and appraisals that we think are associated with OCD. And we see now that some of the developments in our work around the integration are increasingly being delivered at hospitals across Ontario and dissemination efforts to get people treated with OCD. The very next area that I'd like to provide a brief introduction to is some of our recent work in the area of mindfulness. Well, what is this? Mindfulness is the awareness that emerges from paying attention on purpose with curiosity in the present moment, non-judgmentally to things as they are. Mindfulness practice cultivates experiential awareness, openness and interest, curiosity, observation, acceptance and allowing things to just be. And even though some of the original work of MBCT was to prevent recurrence of major depressive episodes, we now know over essentially 2 decades of randomized controlled trial work that we actually have mindfulness as a significant evidence-based treatment for mood and anxiety conditions. So here's a meta-analysis by Stefan Hoffman and colleagues showing that MBCT improves symptoms of anxiety and depression across a relatively wide range of severity, even when these symptoms are associated with other conditions like medical disorders. This is based on 39 studies. What are the mechanisms of action in mindfulness and how are they different from CBT perhaps? Here, maybe one way of answering that question is looking at a scale that measures mindfulness skill sets. This is the 5-factor mindfulness questionnaire. And basically it says to become mindful and to develop a mindfulness practice and to be in a position to reduce mood and anxiety symptoms, people have to be able to become more observing, to be able to stand back and describe things with space and distance from their inner experience, to act with awareness, to be non-judging of inner experience, and to get off automatic pilot and to be non-reactive. If we bring this approach over to our OCD model, maybe the place at which OCD modeling of mindfulness is here, like in our earlier work of cognitive therapy to try and change the way people appraise the meaning of the intrusion and engaging in trying to reduce negative appraisal and belief material. In mindfulness, the goal with the arrival of the intrusion is to be more experientially aware of its arrival and to not judge and just be present with the arrival of the intrusion, sitting with it, but maybe not reacting to it and just not being on automatic pilot, having greater tolerance for the aversion that comes in the emotional state, and being poised for decisions that can be made. So it's like slowing down, grounding one's attention in the breath. So it may be that in OCD, we can actually see benefits of people responding differently to the intrusion in the way they control their attention around the arrival of the intrusion. An example of an obsessive thought: what if I didn't lock the door? In that moment, if it was cognitive therapy, we might actually ask questions about the likelihood that that thought's an exaggerated threat appraisal. Well, in mindfulness, maybe we're just going to say, can you gently bring your attention back to the breath or your body? Can you ground yourself in that moment and stay present with it? Can you watch yourself and notice the urge to ritualize, but not respond, not give into it, but perhaps just ride the wave of the urge? And my colleague Lance Howley likes to talk about riding the crest of the urge wave. And maybe an important contribution of mindfulness could be helping people learn different ways of recognizing and being with urges, but not acting on them. Just being able to accept the discomfort of the urge, watch it, and ride that urge like a wave until it dissipates. And so some of the mindfulness strategies seem to be tailoring the approach to both the arrival of the obsession and the compulsive ritual in a different way than cognitive therapy is. It's certainly different than ERP. We started with Drs. Siegel, Williams, and Teasdale's mindfulness-based cognitive therapy manual. And with Lance Howley and other colleagues, we began to try and tailor the content so that it captured all of the strengths of MBCT, but also became more OCD relevant. Unbeknownst to us, a group at Hamilton, led by Randy McCabe and her colleagues, were also doing the same thing. They were taking an MBCT protocol from depression and morphing it over to look at the impact on OCD. And their study showed in those who had already received CBT for OCD but had residual symptoms, that when they did a mindfulness intervention, they got a very large treatment effect on Y-box change. And you could also see that mindfulness facets were improving in a medium effects level. We had been doing the same work where we took the manual and adapted it for OCD. And here's our equivalent sample. These are individuals who are being previously treated with CBT and then who received an 8-session mindfulness intervention. And you can see our effect size nearly matches exactly to what Hamilton had found in their post-CBT sample. But we also had another cohort where we tried to see if mindfulness could be successful on its own, not post-CBT, but as a standalone intervention. And there we were finding a very large treatment effect for the mindfulness intervention. One possibility is that these effects were still gained not because of the mindfulness strategies, but because of the other things that go on in groups that we run in our clinic, like universalism and psychoeducation about OCD and other things that people can do when they help each other in a group. So we decided to conduct another study. This is led by my colleague Lance Hawley at Sunnybrook, where we got a consumer-graded wireless headset, the Muse. Some of you may know it. You can buy this at, I think Best Buy even, through the New York Times. And you can do home-based meditation. And it actually records EEG when you are actually meditating. We took 100 patients with OCD and we randomized them to either receive 8 weeks of the Muse doing Muse work at home or a control condition. And interestingly, we found over 8 weeks of meditating at home with guided meditation that we are actually reducing YBOC scores, not dramatically, not the kinds of numbers that we might see in CBT, but certainly equivalent to a large treatment effect. And again, a 7-point change on the YBOCs is a significant improvement. And we often see between 5 and 7 points changing in a second or third layer medication. So kind of exciting that here just meditating at home can seem to impact on YBOC scores. And then because we could record EEGs, we actually found that both from 0 to week 8, that people that were receiving the Muse actually had improvements in their alpha and beta waves. And these two are indicative of less mind wandering. And so you can see no changes in the control condition, but the experimental condition receiving the Muse headset showed improvement in less mind wandering. And those EEG improvements actually correlated with YBOC symptom reduction. We've taken these pilot results and partnered Sunnybrook and the other team at McMaster with Randy McCabe and her colleagues. And we are now in the midst of conducting a large-scale randomized controlled trial. We're having people come through and we're randomizing to either receive 12 weeks of CBT versus 12 weeks of mindfulness or a waitlist control. And we're just going to be able to examine not only the standalone efficacy of mindfulness for OCD, but we're going to be able to have a close look at whether or not the mechanisms between these two psychological treatments are similar or different. And just to highlight my collaborators. I will take just a final few minutes to talk a little bit about a non-psychological treatment intervention that we've been studying, and it's looking at the role of exercise in OCD. We have a very voluminous literature showing that exercise is impactful on depression. Effects usually hover around 0.8, a very large treatment effect. And the results have been so convincing that if you look at international guidelines, we actually see structured exercise across 12 weeks being indicated as an evidence-based treatment for depression. Interestingly, there's been virtually no research on exercise in OCD. Just a couple real small studies that took small cohorts of 11 and 15 and then looked after either 6 weeks or 12 weeks of aerobic exercise, whether or not it impacted on YBOC scores. And both studies showed some potential for structured exercise, particularly over 12 weeks, reducing OC symptom severity. We conducted our own pilot. We wanted to ask the question, what happens if we integrate 12 weeks of aerobic exercise with our CBT? Does adding exercise and talking about exercise in our CBT groups actually improve efficacy? We wanted to make this a more ecologically valid study, so we partnered with Good Life. And so people didn't come into the lab to do their exercise. They actually did exercise in the community at their local Good Life gym. And these are the types of aerobic exercises that were recorded across the different phases of our research. And with the 11 completers, you can see that each patient participant receiving CBT but also doing exercise showed fairly large improvements in their Y-box. The overall effect size for combining CBT and exercise in our small pilot was way up above 2, type of effect size that we wouldn't ordinarily see in either the medications or ERP, cognitive therapy, or its integration for OCD. These effects combining CBT and exercise in our pilot exceeded what we typically see for CBT overall, and they also exceeded the 2 studies that just looked at exercise alone. So we took this pilot work and we embarked on a CHR randomized controlled trial where we had 125 patients diagnosed with OCD, diagnosed and randomized to either receive CBT, to be in a waitlist control condition, to receive CBT plus exercise or exercise alone. Overall, our study didn't support our main hypotheses. We actually found that CBT with or without exercise produced strong equivalent gains and better than exercise, and exercise wasn't any better than the actual waitlist control. So overall, we saw symptom improvement, but the exercise condition did not beat the waitlist control, and CBT exercise didn't beat CBT alone. Interestingly, the only other randomized controlled trial published, Abrantes in 2017, also took those who had been receiving medications and were randomized to either a waitlist control or exercise, and they didn't find in an RCT framework any significant benefits of exercise in OCD versus the waitlist control either. But when we did another general linear modeling approach and looking at exercise across the duration of the treatment, when we collapsed exercise or CBT exercise, in other words, when we looked at anybody receiving exercise in the trial, we got a dose effect. The more exercise you do, overall, the better your outcome. And it occurs, the benefits of exercise occur later in the intervention. So early exercise, when people on average have had about 10 episodes of exercise, their Y-box changes less than 1. When we start moving up to 40 to 50 bouts of exercise, we start seeing a corresponding change in 3 points on the Y-box. So it does look like we get this dose effect. The more exercise you do, the better the outcome. Why are these effects occurring in the exercise of OCD? We didn't test that directly we didn't test all of these mechanisms within our trial. It's been hypothesized that maybe exercise improves OCD through reducing anxiety sensitivity or inadvertent exposure to bodily symptoms and gaining the ability to decatastrophize internal states, or some kind of internal physiological resilience. Or maybe the improvements occur through changes in general mood, although we didn't find that, nor of other studies. We had actually placed our chips down on the fact that maybe the changes in exercise and OCD could be occurring through changes in the brain. We know that there is some degree of neuroplasticity and hippocampal neurogenesis in exercise in some studies. Some studies have implicated BDNF in the cognitive changes that we see in exercise. And so we measured these things in our study. We looked at BDNF, the gene, we looked at BDNF serum levels, and we looked at a very large neuropsych battery, pre, midpoint, and post. And I just selected out one of the tests just to show the news, which is we really got no effects on cognition and exercise. And we looked at all of our measures. They are changing from pre to post, but nothing differentially in exercise compared to the waitlist control condition. What do we know at this point? Well, structured physical exercise is a feasible intervention for OCD. It shows a dose relationship to OCD symptom improvement. We can integrate exercise into our standard CBT approach by starting each session by reviewing exercise, troubleshooting barriers to working out, trying to use motivational enhancement to promote engagement, and setting exercise homework goals, just like we would with exposures and cognitive therapy tasks, and also helping people establish exercise buddies and other supports that can help them work out. And just to acknowledge the collaborators on that work. And to say that I guess these are kind of aspirational future treatment guidelines for OCD that I think we certainly have very good ERP cognitive therapy and now integrated treatments. We are moving towards establishing mindfulness-based therapies as a significant and successful treatment for OCD. There seems to be a role for structured exercise, particularly in combination with psychological treatments. And we are also beginning to test the potential benefits of third wave interventions like acceptance and commitment therapy. And I know as Peggy gets her slides, I was just going to leave up the brochure for the active recruitment we're doing right now for our large-scale CBT mindfulness study. So if anybody would like to refer patients with OCD to our study, we're currently enrolling. Thank you.
I know, Peggy, yeah, go ahead. I know you wanted to say a couple of things. You're muted, Peggy, you're muted.
Here we go. Sorry, I'll just confine myself to a couple of quick comments, if I may. So I was going to very briefly introduce some of our work on the genetic basis of OCD. And I think what I will do is just jump to, we began by doing candidate gene studies back in the 90s. This is myself and colleague Jim Kennedy, who has been my dear friend and partner in this work. And as you can see, you know, I've highlighted here a few of our best findings, a number of findings across the genome. The problem, however, with our traditional genetic approaches, which were the best we could do in the 90s to early 2000s, was that we were limited to having genes that were hypothesized to be of interest, that were implicated through neurobiological research. And so the goal really for the last 20 years was to switch to a more agnostic approach, the genome-wide association approach, where we could test all the markers across the genome. And I've been fortunate enough to be one of the early members of, first of all, an international collaborative group pulled together by the International OCD Foundation. And in the last 10 years or so, as part of the Psychiatric Genomic Consortium, the PGC, which is a US-based international collaborative group. And so we've been able to try and advance OCD this way. But just to give you a quick snapshot, our first genome-wide association study in OCD came out in 2013. Although we had a pool of about almost 1,800 cases, including cases and family members, we were dreadfully underpowered for this kind of work. And for those who are not familiar, these are examples of Manhattan plots that are not significant, showing probabilities at the approximately 500,000 single nucleotide polymorphisms we would test across the genome. By way of comparison, what we're looking for is a Manhattan plot that looks like the Toronto skyline, mostly low with a few high peaks for tall buildings. And you can see we have not got there, but one of the early signals that has emerged from this work has been hints of signals around glutamatergic genes exclusively. I'm going to skip through some of these to come to our most recent genome-wide association study, which, as you can see, has grown tremendously to a sample of 14,000 OCD cases. And at this point has one to two SNPs that really exceed the significance level of 10 to the minus, well, sorry, that approach the significance level of 10 to the minus 8 that we need for this kind of work. And for those who are wondering, the kind of samples that really have been most productive in the world of schizophrenia, bipolar, autism, etc., have really been samples of 25,000 or more. But this work is interesting in that we're beginning to find SNPs, single nucleotide polymorphisms, or common variants that do explain a significant degree of OCD's heritability and highlight that genetic risk is shared across a number of other disorders. There are pleomorphic vulnerability genes that seem to increase risk to a number of these disorders broadly. I think this is just showing it in another recent study from our PGC collaborative group, just looking at how these common mental health conditions seem to group somewhat, with OCD most tightly genetically linked to anorexia and Tourette syndrome, but certainly showing clear ties to everything else in this range, including bipolar disorder, autism spectrum, ADHD, depression, and schizophrenia. And the future does look bright because there are large population-based samples which are coming. And hopefully in the years to come will get us over that threshold to the power we really need. I also wanted to highlight our group has been very actively involved in looking at pharmacogenetic approaches. And one of the beauties of this approach is that it is highly translational. If we can identify risk genes that are important in predicting response and toxicity, we could greatly enhance our outcomes. I think to skip to the chase, the OCD work is really kind of early. This is a table of some of the studies that have been done out there showing at this point greatest consistency around the pharmacokinetic gene in the liver, the cytochrome P450-2D6 enzyme, where it's just highly heterogeneous, as all of these liver genes are, with a lot of us carrying common mutations, as well as the neuronal serotonin transporter, which has shown some consistency around response. And the last thing I wanted to highlight was around our intensive treatment program. This is showing you our efficacy prior to COVID. And if we look at decline in Y-box, you can see a really nice improvement of about 45% from a mean entry of 30 down to about 18. The question is, and this is just showing the people we've taken across the province and increasingly from other regions of Canada, almost every province at this point. But what was really interesting was having to adapt to COVID. And so I just wanted to highlight, we have tried to look at this by moving initially to a virtual model and in more recent, the past year, to a hybrid model, which we think is quite innovative. And I think you can see this blue highlighted quote by one of our clients who really found attending virtually to be the best form of CBT for him because he was able to work on his OCD at home where his symptoms are really based. And this is just to show our outcomes as compared to pre-pandemic and post-pandemic in those who still received treatment on site with actually a shortened program and those who have been attending virtually. And it is looking promising. And what we're most pleased about is that this has enabled us to improve access to our care. So in summary, we've worked really hard at TADC to better understand OCD and improve the way we deliver treatment and identify alternative treatments. Neil's told us all about a number of these psychological treatments. And in terms of genetics, we're kind of on the cusp, I would say, of really understanding vulnerability, but pharmacogenetics is showing promise. And on that note, let me stop here.
Thank you, Peggy and Neil. I appreciate it. We've got a couple of minutes for questions. So one of the questions that they were asking was, is there any difference between SSRIs and SNRIs in terms of responses and doses and how high you have to go? Peggy?
Sure. So generally speaking, our rule in OCD is that best efficacy is seen at the highest end of the dose range, often exceeding the dose range for depression. And that is true across the different categories of medications we use. We have the best efficacy data for SSRIs. There is limited efficacy data for SNRIs and excellent efficacy for clomipramine, but with more side effects in its profile. So we would use all of those agents.
Thank you. This is for Neil. In terms of the beneficial effects of mindfulness, does it persist if people don't continue this daily?
In OCD, I think that question remains untested. We're going to have a follow-up phase in ours, only a 3-month follow-up phase. In terms of the long-term sustainability of gains in the mood and anxiety disorder, I believe there are follow-up studies that show that the gains are maintained in short periods of 3, 6, 12 months thereafter. I'm not aware of long-term studies, but I think they may also exist showing that once people get these skills and continue to practice them, they can continue to bring them to bear on their experience. But it probably does take ongoing practice, which is the challenge, I think, in all of our psychological treatments, is to keep people working on the skills over time.
There was a question about ASD and people on the spectrum. Is there any modifications you have to do in terms of treatment?
I can start. So actually, this has been a real area of interest for us. As many of you may know, CPA is ongoing these last few days, and we actually just presented a workshop on OCD and ASD yesterday with colleagues at the Israeli Center. And what we find is that, at least if we're speaking to people of normal intelligence, those in the normal intelligence range, that CBT can be used, but needs to be adapted in terms of using multiple sensory modalities, often a lot more focus on visual means as a way of helping teach the information so that there is retention because of more difficulties with that. Looking at more concrete outcomes as well can be helpful. More time is needed.
Absolutely. One last question. Do you analyze any remitters of, OCD treatment?
Sorry, the question is, do we analyze remitters?
Yeah, I think so. In the white box, less than 10.
Absolutely, we will reach, Neil can speak to this, we certainly have a good percentage, around 30% or so, who attain remission status with our psychological treatments, and a somewhat smaller percentage within that pharmacologically. But we don't at this point have really good predictors of how to identify in advance who those fortunate people will be.
Wonderful. As I mentioned, it's so great to have you, Peggy and Neil. I always learn so much, and the audience is so grateful. So thank you again. Ari, did you want to say any final words before we end today?
No, just thanking both Peggy and Neil. It's been, as you said, a very exciting ride of over 10 years. We arrived at Sunnybrook around the same time, and just watching your careers take off and the impact that you've had through your research together. You're a wonderful duo, and we're very proud of your accomplishments and the impact that you're having on the treatment of OCD and spectrum disorders and anxiety disorders across Canada. So thank you.
Thank you both.
Thank you, Ari.
Thank you.
Thank you, everyone. We'll see you next month with the Ontario Shores Grand Rounds. Take care. Bye.
This webinar will end in 5 seconds.